I'm Andrea. I am an associate professor from the College of Pharmacy at Dalhousie University. David will be speaking about insomnia, sleeping pills. He's going to talk about a specific type of sleep therapy called cognitive behavioral therapy for insomnia. And it's really important that with thinking about the abbreviation CBT-I, that little I is super important when we're talking about how to help and manage insomnia. One of our priorities for this session is really to help you become familiar with SleepWell itself. David's going to provide you with some information that will encompass an overview of the tools that are on the SleepWell website, the resources, the recommendations, and also recent findings from a study that was done in New Brunswick, Your Answers When Needing Sleep in New Brunswick study, or the YONS MB study. Just to give a brief introduction about David, he is a professor with the Department of Psychiatry at Dalhousie University in Halifax. He completed training in pharmacy at the University of Toronto and the University of British Columbia, and completed a graduate degree in community health and epidemiology at Dalhousie University. He's the director of community psychiatry research and has been recognized for his teaching and community support over the years. And he is a co-developer of the SleepWell Research and Knowledge Translation Program.
So let's start off just talking about insomnia, and so that we're all kind of understanding the same thing in terms of its definition and what it includes. So I think it's fair to say that insomnia is something that almost all of us can relate to. It's experiencing difficulties with getting to sleep or initiating sleep or maintaining sleep. And so that could be in the form of you go to bed, you have difficulty getting to sleep, or you wake up in the middle of the night and you have difficulty getting back to sleep. Or if you wake up too early, you can't get back to sleep at all. So that can be something that happens when we get a little bit older. We have this middle of the night waking, or we wake up too early. And for people who are quite a bit younger, they tend to have more of the problem of having difficulties with getting to sleep. And now insomnia is not insomnia unless you have something the next day, whether it's significant distress because of your sleep problem or actual impairment of your functioning. And it's often obviously associated with feeling quite fatigued during the day. And from a diagnostic perspective, we break it down to short-term or episodic insomnia. And that's having sleep problems like we just described for 3 nights or more per week, and often it's every night of the week, for less than 3 months. But if you have it for more than 3 months, then it's known as chronic insomnia, or otherwise known as persistent insomnia. So who experiences insomnia? So in any given year, about a third of us will experience difficulties with sleep through the night, through the night. And about 15% of us will actually have next day symptoms, and about 6 to 10 of us will actually meet the criteria of chronic insomnia, meaning most nights of the week we're having difficulties with sleep, and it's lasting for months and months, and in many cases actually years and years. And so who does this happen more often to? Well, 40% more often in women compared to men. It increases with age. So older adults tend to have much more insomnia than people who are in their teens or early 20s. And the risk increases substantially with psychological distress, mental health diagnoses, or physical health diagnoses. So chronic health problems in general. And what are the causes of insomnia? And I could spend time with you for, half an hour or so just talking about all of the causes. But so we don't spend too much time on it. I just want to point out there's this very useful model of the causes of insomnia, breaking it down to the predisposing factors, which are really our temperaments. Some of us are a little bit more likely to have insomnia simply because of our personality, our temperament, our genetic factors, things we can't really make a lot of change in. And then there's the precipitating factors. So what triggers insomnia to either get worse if you already have insomnia, or to come back if you've had it before, or for you to have it for the very first time? So we think of psychological distress factors like losing a loved one, losing a job, having to move, other kind of things along those lines. And then the third one is the perpetuating factors. And I actually want us to be a little bit more focused on the perpetuating factors. When you have a few days, weeks, or even months of insomnia, we start to do things that actually might be associated with perpetuating insomnia. So imagine you're going to bed and you're trying to fall asleep, and just like last night and the night before, you haven't been able to fall asleep. It's like you're expecting to have troubles. And when you're expecting to have troubles like this, your brain is activated. And of course, you're not going to be ready for sleep if your brain is activated. Some people think of it as having their mind racing. Every time they turn the light out, their mind starts to race. And so you've now got this classical conditioned association of being in bed and being frustrated because you're not able to fall asleep. And so this can go on. And sometimes what people do is they go to bed earlier with the hope that tonight they'll have a better sleep, but they only get more frustrated because they're in bed longer while awake. And then the next day, they're maybe even more tired because of the bad sleep. So now they're starting to have one nap and then maybe several naps, or even long naps, or naps that go into dinner and after dinner. And so napping can actually interfere with something called our sleep drive, making it difficult to sleep. So all of these perpetuating factors need to be addressed, especially if you have chronic insomnia. All right, so that's enough about getting us all on the same wavelength about insomnia. Let's talk a little bit about sleeping pills. So here's a list of medications and substances that are associated with causing you to feel sedated or sleepy or tired or fatigued. They can make it so that bringing on sleep can happen a bit faster. And if they have a longer effect, they can help you to stay asleep. And we'll talk about by how much in just a couple of slides. So I wonder if you're looking at that list and you are taking a sleeping pill of some kind, you see it on this list. At the top circled there is the most commonly prescribed sleeping pill across Canada, a medication called Zopiclone. There are other Z drugs that are available also, and that's how we call them, Z drugs. And then there is a related family in terms of how the medications make you sleepy that are really well known, called the benzodiazepines, or otherwise known as the benzos. And Ativan, the first one listed there, or lorazepam, is a very commonly used one, but there's quite a few other ones. There's other classes, sedating antidepressants. Some antipsychotic medications are actually used for insomnia, although it's not necessarily recommended because their most potent effect at a low dose is sedation as opposed to their antipsychotic effect. So just in general, there's a whole host of medications available to us that have that sedating effect that are often used for that specific purpose. And on the right side, there's a few different natural sedatives, so-called natural sedatives. I would say cannabis has become more popular since it's become legalized across Canada. And some people will use alcohol to help with the onset of sleep, but alcohol actually breaks sleep up so that it helps you get to sleep, but not keep you asleep, and it fragments sleep. So it's not a good overall sleep aid. So with that in mind, we're kind of talking about all of these medications and substances tonight when we're talking about sleeping pills. So sleeping pills in general have a very limited role in the management of insomnia. Choosing Wisely Canada actually recommends don't use the most commonly prescribed medications, the benzodiazepines and Z drugs, or other sedative hypnotics in older adults as the first choice for insomnia, agitation, or delirium, because the balance between their benefits and risks is actually tilted towards risks, especially in older adults. And it's not just Choosing Wisely Canada. There are other campaigns that are going on around the world that all say the exact same statement to avoid the use of the benzodiazepines. And if we look at Zopiclone specifically, when we look at the information that's available to prescribers, physicians, and pharmacists, the information from the pharmaceutical manufacturer actually states Zopiclone is indicated for the short-term treatment and symptomatic relief of insomnia. Treatment with Zopiclone should not exceed 7 to 10 consecutive days. And if it does, for more than 2 to 3 consecutive weeks, it requires a complete reevaluation of the patient. So this is not exactly what is actually happening in practice. This is an insight into what we see across the age groups in terms of sedative hypnotic use. And this data comes directly out of Alberta, but there are data from other parts of Canada and elsewhere in the world that essentially shows the same thing. As you increase with age, the probability that you're taking a sleeping pill significantly increases. It's highest in women compared to men. And the probability that you're using them long-term increases substantially. So in this study, approximately 70% were using sleeping pills for more than 30 days, and the actual average was 161 days in this 1-year study of Albertans. When we look across Canada, and I'm just going to leave this slide there for a moment for you to see where you fit into the rates of chronic use of sedative hypnotics in Canada. And this is by people 65 years of age and older. This is the data that's available to us from CBTI, or the Canadian Institute of Health Information. And this data is probably the most recent Canada-wide data that we have available to us. Unfortunately, Quebec's not included in this. The data is not available from Quebec, so that area is missing out, as well as the territories. But you can see that there is a bit of an East Coast shift, if you will, with higher rates of use in New Brunswick, Nova Scotia, and Newfoundland relative to the western side of Canada. And if you're in Saskatchewan, you might be patting yourself on the back with the quite low, relatively speaking, rate of sedative hypnotic use in terms of chronic use, long-term use in older adults. All right, so now let's take a quick look at the sleeping pills' effectiveness, and then we'll go on to some of the side effects or harms or dangers or risks associated with sleeping pills. So the first graph is really to show us what typically is seen in well-designed clinical trials when you're comparing the most commonly prescribed sedative hypnotics, the Z drugs, to a placebo pill. So the people in these studies are in the study for usually around 1 to 2 weeks, but sometimes up to 4 weeks, and they're taking the sleeping pill every night. And so after 1 week, 2 weeks, or 3 weeks, what is the average increase in time asleep overnight? And it increases in both groups. You get about 35 more minutes of sleep if you're just taking a placebo, an inactive pill, while you're in the study. And you get 58 more minutes if you're taking the Z drug. So the total extended period of time sleeping on average in these studies is 23 minutes. And when we look at how fast you're getting to sleep, the rapidity, I guess, of getting to sleep is 10 minutes. So you've shortened your time to fall asleep with the Z drug by about 35 minutes overall, but in the placebo group, it's about 25 minutes overall for a 10-minute advantage for zopiclone in this case. So let's have a look at what are the safety concerns with sleeping pills. So when we usually talk about sleeping pills, this is the list of concerns that are raised. There's a couple of extra ones that are in there that are not necessarily known by even the most up-to-date physicians and pharmacists, because the data is relatively new and not necessarily in the higher profile journals. And I'll point that out in a minute. But memory problems, balance problems, injuries from falls, pneumonia. So that's one that I would say many people are unfamiliar with. Impairment of next day driving, the dependence and withdrawal issues, physical dependence and psychological dependence to some degree, drug interactions, so mixing of different medications causing problems, and sometimes overdose death related with the mixing of these medications. These are the sort of top list of concerns associated, especially with the Z drugs and the benzodiazepines. But I think it's fair for us to actually look into this just a little bit deeper. So it's not just memory problems. We know that it's difficult for us to remember what we have done. And after taking a sedative hypnotic, and if we're taking them every night, that means that we probably have the sedative hypnotic in our blood for the most part of the next day because of how they accumulate in our blood. But they also can impair alertness, how we're thinking, how quickly we're thinking, and they're also associated with cognitive decline. Now, I say the word associated because we don't know if it's a causal association or a coincidental association, but there are quite a few studies that demonstrate higher rates of sedative use are also associated with higher rates of cognitive decline or dementia. In terms of injurious falls, when you look across all the studies, taking sedative hypnotics increases your risk for injurious falls by about 60%. And when we look at the specific kinds of injuries, the risk for bone fractures increases 66%. The specific bone fracture of greatest concern is hip fracture, and this concern increases as we get older. So a 52% to a 90% increase in hip fractures in people who are currently taking sedative hypnotics is particularly of concern in people who are 80 years of age and older. And then the risk with pneumonia seems to be related to the effect of the sedative hypnotic Z drugs and benzodiazepines on cellular immunity. There may be other mechanisms that are associated with this, but if somebody develops influenza, their risk of developing influenza-related pneumonia as a complication increases by 325%, and death from flu-related complications increases between 240% and 2,000%, so 20-fold increase when you're currently taking a sedative hypnotic from those classes, the Z drugs and the benzodiazepines, when you develop influenza. Zopiclone and a few other sedative hypnotics are associated with next day driving impairment. There are some very good studies using on-road driving tests that have demonstrated that if you take Zopiclone at 11 p.m. and drive 11 hours later or before that, at 10 a.m. or before that, your level of impairment is the same level of impairment as if you have a blood alcohol content of 0.08. And as I'm sure you know, that's the level at which your license would be revoked for a year because of your level of impairment related to your blood alcohol content. So we're quite concerned about this as a specific issue because many people don't realize just how impaired they may be. And I particularly think of people that take a sleeping pill at night, wake up in the middle of the night, take another half dose, and then get up in the morning and are behind the wheel of a car first thing in the morning, sometimes at 7:30 or 8 in the morning. There is a vicious cycle that is well understood that when you take sleeping pills for a period of time and then abruptly stop them, one of the first experiences that you might have is withdrawal-related insomnia, which makes you think that you need the sleeping pill, or you recognize that stopping sleeping pills is associated with insomnia, and it might just be easier to stay on the sleeping pill to avoid the withdrawal-related insomnia. So that can be a vicious cycle. That can be an issue and challenging for us to stop. But the good news is we do know how to safely and permanently help people stop taking sleeping pills. And that is to follow what's called a gradual dose reduction program that's developed specifically for you. And the programs look kind of like this in general. At the start, you reduce the dose gradually. And near the end, you slow the dose reduction down a bit more. And you're really advised to contact your prescriber, your physician, and your pharmacist, nurse practitioner to give you input into the overall program for how you want to reduce your sleeping pill dose. But gradual dose reduction is the critical component of how to do it safely and permanently. And I don't want you to think that this is all about just stopping sleeping pills. This is actually all about getting a better night's sleep. And so stopping sleeping pills is really to be replaced by something that's more effective and safer for you, and something that you can take or do for a short period of time and not necessarily for a long period of time. And that all brings us to something called cognitive behavioral therapy for insomnia, or CBTi. We always call it CBTi because it's quite a mouthful to otherwise say cognitive behavioral therapy for insomnia. And ultimately, it is the most evidence-based form of sleep therapy that is available to us. When we look at CBTi, take a closer look at CBTi, it actually has 5 components. Some people will argue it has 4 components. We wouldn't include the sleep hygiene or sleep education on the right as part of CBTi, but for our purposes, we do include all 5 components. So CBTi overall has been researched across the ages. So we know it works in teenagers, young adults, older adults, people who are well into their retirement years. We also know from really good clinical trials that it works well in people who have other health issues, physical health issues, as well as mental health issues. So if you asked me, does it work in people who have sleep problems, insomnia specifically, and these other health issues, I actually think there's a really good chance that I'll be able to say, yes, it's actually been studied in that specific subgroup of individuals. So the evidence base for CBTi is rich. It's also been studied in different specific formats. So that really means it's available and effective if it's therapist guided. And CBTi really came from the development of it being provided by a therapist to an individual. But the demand for effective CBTi really goes well beyond the availability of therapists. So other approaches have been developed and studied and have been shown to be effective. So there's a whole range of self-help approaches that are out there, and I will be introducing you to some of them. And then there's quite a broad collection of hybrid approaches where you're really taking a self-guided approach, but you also have somebody that you can go to support you through the process of CBTi. So what does a CBTi program actually look like? And this is really a generic rendition of your average CBTi program, whether it's therapist-based, group therapy-based, a hybrid program, or one where you're really just leading it yourself. It always starts with and is centered on your sleep diary. So over the program, which usually lasts from 4 to 8 weeks, and so here it's demonstrated to be a 6-week program. I would say most programs are 6 weeks long. Some are a little shorter, some are a little longer. You start off filling out your sleep diary, and I'll show you what that looks like in just a minute. You fill out your sleep diary, and after a week or so of doing that, you get a good idea of your sleep patterns and what your sleep numbers are, and then you start to build in some of the components of CBTi. So some of the easiest components to build in are around sleep hygiene, but then there's also something that we call control. The psychologists call it stimulus control, and I'll show you what that means in a minute. And then adding a component that really builds your sleep drive so that when you're in bed, you're sleeping. You're not in bed being frustrated anymore. So we'll go through that also. And then there's relaxation therapy techniques and cognitive therapy techniques, and we call those relax. Cognitive behavioral therapy for insomnia, or CBTi, is a short-term treatment and is not designed for long-term use. True or false? In fact, it is not designed for long-term use. It really is a short-term intervention for long-term gain. So I think I would say this is a true statement. CBTi is a short-term treatment and is not really designed and is not necessary for long-term use. This is a study that was done in Quebec City a while ago, but it's a really great representation of what we tend to see with CBTi. And what I like about this study is it's a direct comparison between CBTi, which is the black line, sleeping pill, a very standard sleeping pill, temazepam in this case, which is the blue line, and placebo, which is the red line. And so it is a study of an 8-week intervention with CBTi, an 8-week intervention with the sleeping pill, and 8-week intervention with the placebo pill. And what's being measured here is essentially your insomnia severity using a specific scoring under the name the Sleep Impairment Index. Higher scores mean more sleep impairment or more insomnia severity. So from week 0 to week 8, the participants in the study received the intervention, the pharmacological intervention or CBTi, and you can see that CBTi improved insomnia severity significantly more so than placebo and the sleeping pills. And then once the treatment was over, they did a follow-up of 3 months, 12 months, and 24 months. And so we have an end of treatment here, but the treatment benefits persisted only in the CBTi group for 3 months, 12 months, and 24 months. So 2 years out, there's still substantial improvement in individual sleep associated with a short-term 6-week or in this case, 8-week intervention of CBTi, where there was no long-term benefits associated with a short-term course of sleeping pills. And nobody's surprised by that. You're not expecting to learn how to deal with your perpetuating factors of insomnia through taking sleeping pills, whereas you are learning how to deal with them when using CBTi. And I think that explains why there's an advantage of CBTi for such a long-term period. So we have available on the SleepWell website this form that actually can be downloaded and shared with others. If you're a healthcare professional, you can keep it in your practice and you can hand it out as needed. It compares CBTi with sleeping pills across a range of considerations. So we just went through the third one, effectiveness, but there are 11 categories in total that compare CBTi and sleeping pills. And I would recommend sharing this one-pager with anybody that you would like to start to consider using or thinking about using CBTi rather than continuing the chronic use or long-term use of sleeping pills. Cognitive behavioral therapy for insomnia, CBTi, is effective when provided by therapists, but more research is needed to evaluate its self-help formats. True or false? Let's go to the next slide, and we'll see if we have enough studies or not for the self-help formats. Oh, let me click that over. Okay, so our website, the SleepWell website, actually has under the CBTi page a little button down the bottom right that actually lists a good number of studies that have been completed involving CBTi. And I encourage you to go to that list of studies. Included in that list are the studies that have looked at the specific different formats. So comparison of different formats, head-to-head comparisons, self-help formats, including books or apps or online services, and then obviously the therapist-based formats. And what these individual studies show, as well as what the collection of studies show in meta-analyses and systematic reviews, is that they are all effective. And so I feel quite confident and comfortable saying to you that we have an adequate amount of research for any and all of the formats to suggest that they are effective. Now, some people might have different preferences for different formats. Some people might be ready to really take a self-guided approach and do it on their own. And other people will feel like, I need a bit of a hybrid approach. I'll do a bit on my own, but I need sort of guidance from a therapist. Or other people will say, I really do want to be part of a group or see a therapist in person. So there's different preferences, but they all seem to be effective. So it won't be much surprise to you based on what I've gone over with you that there are clinical practice guidelines for the management of insomnia across the world. So there's American guidelines, European guidelines and Canadian guidelines, and they all recommend the same thing. They recommend CBTi as first-line therapy for the treatment of chronic or persistent or recurring forms of insomnia. And they really do clearly relegate the pharmacological approaches, the medication approaches, to second line, where you would consider using the medications when CBTi is not or is no longer a viable option because it's been tried and has not worked out for the individual. And this really, as we know, is not what happens currently. Very often, clinical practice guidelines are a bit of ahead of the curve, and we're trying to get clinical practice to catch up with the guidelines. And that is exactly why we developed SleepWell. Ultimately, our goal with SleepWell is to transform how insomnia is treated in primary care, in general practice, instead of it being based, which is really primarily in the pharmacological side of things, but more so on the behavioral side of things, and trying to make that as easy and accessible as possible. So there are two main objectives of the SleepWell initiative: is to achieve better insomnia treatment outcomes with the use of CBTi, and to reduce the overuse of sleeping pill use, especially in chronic insomnia where it's not recommended, and thereby, in doing so, reduce its related harms. So I have one more polling question for you. SleepWell is a specific type of sleep therapy. True or false? The way I think of it is, SleepWell really isn't the sleep therapy. CBTi is the actual sleep therapy. So what SleepWell is a source of recommendations for how you can identify and access bona fide, scrutinized CBTi programs. And SleepWell actually provides you with information about CBTi, what it is, where you might find it, what to expect from it, and so forth, what tools you might need. And we have created tools, or we have recommended specific tools, as well as resources, all to support your journey, 6-week journey, 8-week journey, 4-week journey through CBTi to help you get your sleep back. So if you've been to the SleepWell website a long time ago, or in the last few days or weeks, this is probably what you saw. This version of the SleepWell website's really been up and running since about 2018. In the last 6 months, we have had 30,000 Canadians use this website, which is astonishing to me. And we've had 10,000 people from outside of Canada using this website. The primary reason people seem to be coming to the SleepWell website is to learn about CBTi. So I'd say 65 to 75% of people who visit our website are there to learn about CBTi, and about 1/3, 40%, are there to learn about sleeping pills and using our tools to help people reduce and stop sleeping pills. So in the top right, you'll see a few menu items. And I just want to point out these icons here, because we're going to come back to the icons, because behind the icons is all sorts of information. So think of the icons as a doorway to the different components of CBTi in itself. If you're going to come to SleepWell and you only have a few minutes and you want to make the most use of your time, where I think you should spend your time is what SleepWell recommends. Now, it doesn't look like this on the website. I've just changed it to fit onto a slide nicely, but it recommends bona fide, curated resources that truly are CBTi. So we have some books that people can purchase, not from our website, but just from typical bookstores and so forth, that are actually self-guided CBTi programs. So many people who are using the self-guided approach actually like the workbook approach best. And these books can offer you a workbook approach that you can finish off in 4, 5, 6, 7 weeks all on your own. Then there are some online programs. So one of them that we recommend is shown here. You can do it all online. Some of them are online and apps. And so it's a bit of a combination. And then the other hybrid model is where you're using an app on your phone and you also have direct access to a therapist through the app itself. And so one of them is also shown here. There's a few more if you go to the actual website. So as I mentioned, there's a lot behind each one of these icons. And if you're on our website, it's really worth your time, I would hope, for you to click on the different icons to learn about what the components are about and to get resources to help you actually use the component. So let's actually just take a quick scan of what these components of CBTi are all about and what you might expect when using these components. So control, or as the psychologists do refer to it as stimulus control, is really an attempt to retrain your brain so that you get to associate your bed with sleep as opposed to being frustrated. Stimulus control or control is go to bed only when you're feeling sleepy. You might have a set bedtime, but if you're not sleepy, don't go to bed until after you start to feel tired. Rise after 20 minutes if you're not sleeping. So that's one of the hardest parts, but that's how you break the cycle of being in bed and feeling frustrated. You can't feel frustrated from being in bed if you're actually not in bed. And so you're trying to break that learned, classical, conditioned response of being in bed, having your mind race, and therefore feeling frustrated. So leave the bed. Maybe you should already have an activity planned for when you leave the bed. Something in low light, something calm, not bright lights, not screens to do when you're out of the bed, and return to bed when you're feeling sleepy. Now, if it happens again, let's say you fall asleep and you wake up and can't get back to sleep for at least 20 minutes, then you're out of the bed and you repeat this. This is something you do short term for long-term gain. So it is difficult to do, but if you do it for a few nights, you're really going to make a lot of inroads in breaking that habit. Related to that approach is something that is often described as the most effective component of CBTi, time in bed restriction therapy. So you're filling out your sleep diary for a week or two, and then you look back and you say, okay, how much time am I actually spending in bed? And based on your sleep diary, how much time am I actually spending asleep? At some point with time in bed restriction therapy, you to being in bed only for the time that you have been sleeping over the past week or two. So you abbreviate your overall time in bed. And so when you're in bed, it's a shorter period of time. You are increasing your sleep drive. How you increase your time in bed is actually based on something called your sleep efficiency, which is the ratio between your time asleep and your total time in bed. If your sleep efficiency gets above 85%, then you're getting to where you need it to be. And I'm going to show you how this actually works on our website. I would say one of the most commonly visited parts of our website is our sleep efficiency calculator. So you're basically filling out your sleep diary using our calculator. So let's say you fill it out and you say you've gone to bed at 10. You tried to start to go to sleep around 10:30. You got to sleep around 11:30. You woke up a couple of times in the night for a total of 30 minutes. And then in the morning, you woke up at 6 and you got out of bed at 6:15. You click calculate, and it calculates for you the numbers. Your total time in bed was 8.3 hours. Your total time awake in bed was 2.3 hours. Your current sleep efficiency is 73%, and your total sleep time is 6 hours. And then there's an interpretation provided along with some guidance. So this essentially is a critical tool, the sleep efficiency calculator, as well as your sleep diary for using time in bed restriction therapy. Here's the sleep diary that we have available for you on the SleepWell website. And the way you fill it out is you get up in the morning, you may be having your breakfast, getting your day started, and you spend 30 seconds to a minute just putting the times in to your best recall. It doesn't have to be perfectly accurate. So if you think you go into bed around 10, you put that in. Time you think you started to go to sleep was around 10:30, and you're just guessing that you think you got to sleep around 11:30. We don't want people to clock watch. So that's a sleep diary. There's lots of different types of sleep diaries out there, but they all have those essential components of just filling in the information to give you an idea of how you sleep, and you can track your progress through your program. There are a number of different relaxation techniques, and on our website, when you click relax, you'll be introduced to a number of them. So you're really trying to prepare your mind and body for sleep. It's something you do right before you're getting into bed, because when you get into bed, your bed is only for sleep. So you get into bed and you turn the light off, and hopefully your relaxation technique has helped you get ready for bringing sleep on. And we have information around cognitive therapy, what it is, and some resources to help you learn about your own potential thoughts around sleep. And maybe you even have some sleep myths that you can identify and overcome. And this is another tool that will help you effectively work through your racing mind that happens to a lot of us after we try to start to fall asleep. And the last one is sleep hygiene. And it's really a 24-hour cycle. It's what can you do during the day to help you sleep at night? What can you do right before bed? And what can you do in bed to help you fall asleep? And it's really practical tips from morning to night to help you prepare to be in a position to have a good sleep. It is, though, considered to be one of the least effective components of a CBTi approach. Many people with chronic insomnia have tried all the sleep hygiene tips and still have chronic insomnia. So they really should be focusing on the other components. All right, just a few other things that are new, and I guess I'm a little bit excited by, that are available to you that are on the SleepWell website. One is our brand new 10 tips for better sleep. And how this is different than the 10 tips for better sleep that you'll find on the internet all over the place is that it's really inclusive of all components of CBTi. I would say the other lists that I've seen about how to improve your sleep really focus on sleep hygiene. This includes sleep hygiene, but it includes all other components of CBTi. So you can print this off. You can have copies available for patients. You can give it to your loved ones. You can try it out yourself. And another component of the SleepWell website that's pretty much brand new, which I'm super excited about, is our storytellers. So we have Faye and we have George. Faye's in English and George is our first step towards making the SleepWell website bilingual. So thanks so much to George for getting us moving in that right direction. These are stories of individuals who have been taking sleeping pills, had been taking sleeping pills for 30 to 40 years, and what their journey was to reduce and stop their sleeping pills and what they did to improve their sleep. And in both cases, they found that the components of CBTi were very quick to improve their sleep over a short few weeks and then sustain the improvements. These videos were recorded months and months and months after they had stopped their years of sleeping pill use and had tried some new techniques to improve their sleep. So I encourage you to watch those videos. And I will add that they do have captions, and the captions are available in many different languages. All right, the last thing I wanted to speak with you about is our research findings. And I'll just go through these relatively quickly. But what we did know was CBTi worked. We developed SleepWell, but what we didn't know is if it was achieving its objectives of reducing sleeping pill use and increasing CBTi use and better sleep outcomes. So in New Brunswick, we did a study where we sent people printed packages. There was 565 participants. The age range was 65 to 92. Females were 2/3 of the participants, and there was 6 to 7 health conditions, chronic health conditions, 7 regularly used medications. And the average person in our study was taking a benzodiazepine or a Z drug for over 11 years. This is what the package looked like, sent by mail. There were 2 other groups, a different package, not SleepWell was our comparator group. And then there was a 3rd group that didn't get a package, and we call that treatment as usual. When people opened the package, they would see inside booklet 1 had a quiz, had information with a lot of images telling them about the dangers of sleeping pills and how to get a good night's sleep without sleeping pills and how to safely stop sleeping pills. This is not all of the pages, but it represents what you would see inside the package itself. And booklet 2, how to get your sleep back, also had a quiz and gave information like I've just shared with you about how to use CBTi components to improve your sleep. So what was found? Well, we were surprised by just how impactful the SleepWell intervention was. 29.4%, almost 30% of individuals who received the package, and that's all the intervention was. After 6 months, we called them up and said, how is your use of sleeping pills going? And almost 30% of them told us, I've stopped using sleeping pills. Another 23% had reduced their sleeping pill use by a clinically important amount of over 25%. This is over 52% actually stopping or reducing their sleeping pills compared to 21% in the treatment as usual group. We assessed sleep onset and other sleep factors. Sleep onset was almost a half an hour faster in association with being in the SleepWell group. Sleep efficiency improved in the SleepWell group. It didn't improve in the other 2 groups. Insomnia severity also was reduced. Daytime sleepiness was also reduced. And there was no worsening of anxiety. It actually got a little better. And there was no worsening of quality of life. It also actually got a little better in the SleepWell group. So we're very happy with seeing reduction in use of sleeping pills while better health outcomes, especially in terms of sleep. So what did we take away? Well, as a direct-to-patient intervention, because we just mailed it directly to people who signed up for being involved in the study, all of them 65 years of age and older, taking sleeping pills chronically, SleepWell reduced sleeping pill use and improved sleep health. For health service planners, it may be of interest to think of it as a low-effort, efficient, and scalable intervention for transforming how insomnia is managed. And it really is a good fit for a health promotion, a sleep health promotion campaign that would be evidence-based and have direct-to-patient components to it. If you're a healthcare professional, you might want to visit the SleepWell website and go straight to our training page. We're involved with the development of the Queen's CBTi training program, which is an on-demand online 8-module program that you're welcome to look at. So just visit this page, scroll down, and you can click on through to the Queen's webpage to get more details around that. And what is next for SleepWell? Well, as I mentioned, we're looking forward to the French translation. We have more information coming for healthcare providers that will help them use the SleepWell website more efficiently. We're doing more research on building and sustaining SleepWell as an intervention. And we're looking for more involvement from you involved in our small group sessions. And Andrea is going to tell you a little bit more about that. So I just want to say thanks so much for everybody participating and listening to this, which really was a lot of information thrown at you all at one time.